thickness. The corneal thickness should be proper and in normal limit, then only the IOP which we take by the way of appellation tonometer can be accurate. If the corneal thickness increase or if the corneal thickness is less, recorded less, the IOP value should be added some value, some deviation value are provided in the form of a chart. Therefore, you have to compare the chart and then only you can calibrate the IOP property. This should be remembered because this will be covered again in glaucoma because corneal thickness is very, very important, very much important. So, why is the cornea? How many layers are there in the cornea? Essentially 3 layers. Essentially 3 layers. One is epithelium. The second is the stroma. The third is the endothelium. Here it's written as 6 layers, but essentially it is 3 layers. Because in between you can see if you separating the epithelial cells and the stroma, there is a layer called as Bowman's layer. Bowman's layer. And then the majority or the bulk of the cornea is produced by the corneal stroma. And then there is a small layer. There is a layer separating the endothelial cells from the stroma. It's called as Descemet's membrane. It's like a condensation of fibers. It's called as Descemet's membrane. So before the Descemet's membrane and after the Descemet's membrane and in between the endothelium and the Descemet's membrane, they have discovered another layer called a Juas layer. Juas is a scientist from India, and he has recently discovered this layer. So it becomes 6 layers instead of 5 layers. Becomes 6 layers. So whenever there is an endothelial detachment, you see postoperatively when you do cataract surgery, that layer endothelium gets detached at the Juas layer. Okay, that's a very fragile layer. So that's what you have to learn. So it is avascular, as you know, and it is devoid of any lymphatics also. Cornea does not have any lymphatics. If there is a corneal ulcer also, there will not be any nodes which will be inflamed. You will not have any lymphatics for that matter. And nourishment, how does the cornea get nourishment? The cornea gets nourishment by way of diffusion from the aqueous capillaries. So aqueous and capillaries. The perilimbal, there are capillaries supplied by the vasculature, and this vasculature will give some type of nourishment. But majority of the cornea is nourished by the way of diffusion from the tear film. Tear film, if it is having sufficient tear film is there, that means the epithelium is nourished very well and the transparency will be maintained very well. So the first thing is you have to study the tear film, and after that the surface cell, the wing cells, basal cells, and the basement membrane. These are the layers of the cornea. So you see that it is stratified squamous epithelium, it is looking like that way, and it is very stratified. And the particular uppermost part of the cornea, that outermost part of the cornea is called epithelium, and then it ends with the basement membrane, and then the Bowman's layer. So Bowman's layer is the condensed form of the stroma, which is a continuous part of the basement membrane. So basement membrane regenerates the corneal epithelial cells. And then the stroma. Stroma, I'll talk to you about stroma, and then there's a Descemet's membrane and endothelium, as I told you. So epithelium is about 50 to 90 microns thickness in stratified squamous epithelium. As I told you, it consists of 5 to 6 layers. aged surface cells lose their attachment and slough off to the tear film. So tear film is something which rinses the cornea. Always it keeps on rinsing the cornea. And then those cells which are shed because of age, they just, and they get washed away by the uh, 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 tear film. Wing cells move to become surface cells. So there's a basal cell, as you have seen in the previous picture. Basal cells keep moving up, and then when they move up and up, automatically they get aged, and then they shed. So normally cells adjacent to the basement membrane can divide and proliferate. The source of this renewal is stem cells, located at 0.5 to 1 millimeter wide band around the corneal periphery. Remember this, that there are stem cells at the periphery of the cornea, where it is attached to the sclera. It's called the limbus. That's called the limbal stem cells. Limbal stem cells, you have to remember that those are the things which are deficient, and that is the one condition which causes the pterygium. Pterygium, it does not go into the conjunctiva. See, the cornea has got uh, upper to cornea there's a conjunctiva, and lower to cornea there's conjunctiva, but does not grow that way. It invades the cornea. That is because there is deficiency of limbal stem cells. You understand? So the pathology of the pterygium growing into the cornea is due to limbal stem cell deficiency. So glucose supply of the cornea is made mostly about 90% by the aqueous. So aqueous has got a lot of glucose. It's aqueous, so it is inside the eye there is an aqueous. So that gives rise to aqueous. And then posterior segment is called the vitreous. Aqueous is the inside of the eye. Outside is tear film. So normal corneal epithelium sheds at regular intervals. It takes normally 7 days for replacement of the entire corneal epithelium. Why this is very important for you to know is when you do a keratoplasty or if you do a LASIK, LASIK is of a very big trend. So they try to scrape off the epithelium, then try to do the LASIK to the stromal areas. So how many days it requires for the entire cornea to regenerate is normally 7 days. That's why people who go for the LASIK, they often ask how much time it takes for the entire corneal epithelium to totally come back to normalcy. So tight gels in the basal cells account for epithelial transparency. You can see tear film is very, very important and in the form of cornea in the nourishment and the nutrition of the cornea. Tear film has got 3 layers again. What are the 3 layers? The tear 3 layers is superficial uh, lipid layer, and then the middle aqueous layer, and the third is mucin layer. The mucin layer is bound to glycocalyx and microvilli. It is the most important part which adheres onto the corneal epithelium. So corneal epithelium has got this microvilli and glycocalyx, and this will go and the tear film will adhere to the cornea and it produces a smooth surface. So basal cells, wing cells, surface cells, I don't think we need to consider too much, we can read it up in the books. What is Bowman's membrane? Bowman's membrane is a very important structure, you have to remember. It binds the corneal stroma anteriorly with the basement membrane of the epithelium. So this basement membrane, you can see the proliferating cells. When you see the proliferating cells in the basement membrane, that particular just after the basement membrane, you can see that it is a proliferating structure of the epithelium. So this basement membrane is a true elastic membrane, and once destroyed, if you see any penetrating trauma or any injury to the eye, which injures the basement membrane, does not get regenerated. But when it is having a relative resistance, and when you see the basement membrane damage, usually causes permanent opacities in the eye. So whenever we look for a cornea, injury of the cornea, we have to carefully see the basement membrane. If it is having any problem, basement membrane is having any ruptures, etc., you can see it is having small radial irregular lines in the basement. So it does not recover. And then you have to only compromise and tell the patient that the visual acuity will be poor because of the irregular scars in the basement membrane produces. Okay, that's very important. But it is not like that. In the case of Descemet membrane regenerates. Basement membrane, uh, uh, Bowman's membrane does not regenerate. So any injury to Bowman's layer will result in opacities, permanent opacities. So stroma is about 0.5 thickness, millimeters thickness. From the major part, that is 90% of the total corneal thickness is formed by the stroma. So that's it's also called as substantia property. So composed of collagen fibrils and then keratocytes, intracellular ground substances. Laminar are many layers and are parallel to each other. They are so nicely arranged in the cornea, and then uh, they are so nicely arranged in the cornea that the regularity of the is maintained, and therefore it becomes transparent. When it becomes transparent, I'll talk to you more with pictures in when I deal with physiology of the cornea. So anterior one-third of the stroma lamina actin and posterior two-thirds of the stroma lamina larger. So this is a little bit more for you. So this is the jewel here, discovered by an Indian in 2013. It's very latest discovery, University of Nottingham. You remember the latest Kurana consists of this layer also. It is included this, and it is the fourth layer of 15 microns thick and strong layer and impervious to air. What has been written about the Duas layer. So Descemet's membrane is the layer before the endothelium. It's a very strong homogeneous layer. See, the layer, the corneal epithelium, the Bowman's layer, and the Descemet's layer, the endothelium, they all maintain the integrity of the cornea so much that nothing passes into the stroma. They cause a lot of resistance to chemical agents, infection, pathological process, and anything. It does not allow even the water to enter because tears are full of water. That the water enters into the cornea, it produces fast. So cornea is said to be in a relative state of dryness. Cornea is usually all the mechanism will keep the cornea dry. So cornea, if it becomes wet, if the cornea imbibes water, then it becomes uh, totally opaque. So this much membrane can regenerate, so resistant to chemical agents, like I told you, and posteriorly cell healthy body in the advanced age. So when you see through a slit lamp, the age in cornea, you will be able to note down small white speck-like structures and the particular posterior surface, so called as Hessel Henry bodies. When you see those things in the cornea deeper layer, you can say that the cornea is having advanced age. Endothelium. Endothelium is of very importance for the corneal transparency. Because it is single layer. You can't afford to lose endothelium. They are flat polygonal cells. And then they form a single layer. And then at birth, then there are about 6,000 cells in density per square millimeter. With increasing age, the number of cells is reduced. So the corneal endothelium is hexagonal. Cells are hexagonal. They are single layer. and then involved in active secretion of proteins since contain highest number of mitochondria next to photoreceptors. You must understand that it is having the highest metabolic index. So metabolism, when it is more in any layer, that means it is multiplication very strong. So we see photoreceptors are being constantly shredded as in the photocycle. Like that, you can say endothelial cells are also being um, shed. Due to age. If some endothelial cells are lost, new cells are not produced. So what happens is these cells which are adjacent to the large cell will increase in size and then occupy the gaps in the endothelium. That's called as polymegathism of the endothelium. The polymegathism of the endothelium is very, very important. And then endothelium has got a special structure called as endothelial ATPase, ATP uh, AS pump. So this always takes out the water from the cornea and then throws the water into the aqueous so that into the epithelium and the whole corneal structure maintains a relative dryness and compact. So that's very important. If endothelial cells count is less, when you do an operation for cataract surgery, you do maneuvers in the antechamber. Some more endothelial cells are lost. Therefore, you'll have a hazy cornea after you do the surgery because when the endothelial cells are lost, the ATP, sodium potassium ATPase pump fails, and then it imbibes. So cornea imbibes the aqueous, and then it becomes opaque. So that's a very important thing which you have to. Even while doing corneal transplantation, also you will see that they will count the endothelial cells. Even if the endothelial cells are normal number only, you can attempt a corneal surgery, corneal transplantation surgery. Endothelial cells are critical number. If they are not present, then corneal transplantation graft is thrown away. Okay. So endothelial cell density slowly decreases as adult and old age. It becomes 2,500 cells per millimeter square must be present. For and then in old age they decrease much. So majority of the cataract surgeries are usually of the aged person. So that is very important. So what is blood supply? This is very important, because cornea is avascular. So how does it get the nutrition? Because nutrition is very important for any structure to survive. And small loops derived from the anterior ciliary vessels invade its periphery from about 1 millimeter and provide nourishment. So whatever the anterior ciliary vessels are coming, you can see a small vessels at the limbal area. So that particular vessels bring nourishment onto the cornea. These loops are in the cornea and the subconjunctival tissue which overlaps the cornea. So loops can be seen subconjunctival. These things have got some important. If only conjunctival vessels get congested, it's called the conjunctivitis. And if the particular corneal vessels get involved, in that particular state, they are state. I'll tell you when we deal with iridocyclitis, such kind of thing. These circumconjunctival corneal vessels will get congested. They become a hue, they become brownish hue. Then that is a hallmark that a segment is involved, anti-segment. What is the nerve supply? The cornea is the most sensitive structure of the body, entire body, because it has got just sensory nerve plexus in the body. It's supplied by two long, short, and short ciliary nerves from the ophthalmic division of the trigeminal. So when they come, long ciliary nerves come and then they pierce onto almost just a little bit posterior to the limbus, and then they quickly lose the myelin sheath. So, and the small fibers will go and they'll be beneath the corneal stroma. The subepithelial plexus will be formed. So there are fine terminal branches, they'll form into the breast membrane and intraepithelial. And there's no specialized nerve endings. These are only sensory organs. And they also do not have any Schwann sheath. So most are concentrated in the antestroma beneath the Bowman zone and send branches forward in the epithelium. So descent membrane and endothelium are not in. Remember, descent membrane and endothelium are not innervated, but anterior surface of the important is the epithelium gets innervated. So you can feel all the pain. Pain is very important reflex, which something hits onto the eye, or even if a small draft or wind blows onto the eye, you can feel the pain because of the nerve endings present in plenty. This is how this trigeminal nerve supplies. Okay, short nerves will pierce into the behind the eye around the optic nerve. So what is the important junction cornea and sclera? It is where it's called the nimbus. Nimbus has got it contains trabecular meshwork and the channel of Schlemm. So these are very important. So Bowman's membrane becomes continuous with the lamina propria. It continues to capsule. Stroma becomes sclera. That's when the membrane becomes valgus line. Then looking in line with trabecular meshwork and becomes continuous with the anterior. So the whole cornea and the sclera at the nimbus, just behind the nimbus, if you can see the trabecular meshwork, iris, ciliary body contains of trabecular meshwork, and then with the draining canal of the aqueous, whatever is produced in anti-chamber, it should be drained into the canal of Schlemm. So nimbus is a very important structure in ophthalmology as far as surgery is concerned or anything is concerned, right? So if there is any vitamin deficiency of vitamin, etc., you will have some problems with the transmission. That's called a keratomalacia. I told you again, keratomalacia. It melts. The cornea melts like a butter. So that's because of vitamin deficiency, which is present in all the developing countries. We don't have, because we are giving prophylactic vitamin A in very small children as soon as they are born. You can see in extended immunization plan in pediatrics. Was transparency maintained? So transparency, there's other mechanisms are there. It's called physiology. Tight junction between the epithelial cells. They won't allow anything to get inside. The tears or whatever water you put in the eye or whatever, any pathogenic organism cannot traverse through the corneal epithelial cells because it's so tight. So they are hydrophobic. So epithelium and the endothelium are hydrophobic. So as I told you, endothelial pump mechanism is one of the things important. It's called a sodium potassium ATPase pump that throws away the water from the cornea into the aqueous. It helps to maintain the compactness and the dryness of the cornea. Cornea should be kept dry. It is dehydrated state. So absence of blood vessels. There is no blood vessel in the cornea. Therefore, if there is any presence of blood vessel, that means you have pathology. If you see blood vessels invading along with the pterygium, that is pathological. There is a small ulcer on the cornea, a small foreign body left behind without taking proper attention. Any anything deposited on the cornea that attracts a small tumor or some tumor cells on the cornea, etc. These will attract the blood vessels onto the cornea. So when the blood vessels invade the corneal stroma, that means the cornea loses its transparency and becomes opaque. And there's absence of blood vessels and absence of pigment and scarcity of cell nuclei in the stroma. So you can see nuclei of the cells only in the epithelium and at the endothelium. But in the stromal area, there's no nuclei because and then they are inactive in nature. So all are uniformly refracted. All the cells of the stroma are uniformly refracting, and the collagen spacing in the corneal stroma are so regular and separated by a distance which is less than the wavelength of the light. So if there is any aberrant light is traversing through the corneal stroma, that will be automatically cancelled. It is regular, it is refracted through the stroma. It is automatically controlled or eliminated by destructive interference with the mechanism. So the light will cancel itself and then that particular thing. You can see noise cancellation. I think so many people of you must have heard about noise cancellation in the earphones. When you are hearing any music, that this music, if there is any surrounding music, surrounding sound disturbances there, the earphones will send a similar type of thing so that that noise is cancelled. That is the latest in the form of sound technology. Here in the light technology, this particular type of regular arrangement, which is destructive interference, is a thing which cancels out all the aberrant light which enters into the eye. So, advanced gear becomes, I told you, there will be small opacities, and then disperse region rates, and if it is torn during surgery, it produces, it curls up, produces vertical slit-like things. You can see it to the slit. What happens when the IOP rises? IOP rises, the gaps between the cells or the endothelial cells will increase. So these small pores will be formed, and then through the pores, the aqueous enters into the cornea and then produces a corneal edema. So edema due to increased intraocular pressure because the cells are separated by the pressure. Eye. So number of methods of corneal analysis are there. The keratometry, confocal microscopy, specular microscopy, anti-segment OCT, orb scan, aberrometer. You write down all these things. These are all very, very important and latest ones. Some of these things have been we'll be discussing when we are trying to analyze the cornea. Physiology pattern. Hello. Hello. I think I have discussed majority of the physiology also, but I wanted to show a few slides. ఏంటి అయిపోయిందా చెప్పలే ఇంకా రెండోది బాగా 10 నిమిషాలు ముందు క్లోజ్ చేస్తా 10 నిమిషాలు ఇంకో So majority of the things we already covered. So I'll just go through quickly. So oxygen from the atmosphere, and then the tear film is what is being supplied, and then they're all technical things which you are present in all the textbooks can go through. These are all the another PowerPoint I wanted to merge, but so pento shunt, hexomonophosphate shunt, hypoxic normoxic conditions, then glycolysis, and then Krebs cycle, citric acid cycle will take place. So corneal transparency is theory. Two theories are there. The one is Morris theory, transparency of stroma. Two theories, you read it, and the regular arrangement of the corneal lamina, stromal lamina. So if they are regularly arranged like this, anything will be cancelled. Any ray which is diffracted irregularly can produce that destructive diffraction. Only epithelium and tear transparency, corneal vascularity, non-myelinated nerve fibers are present. I told you when it enters in the cornea, the nerve will lose its myelin sheath and then only the fiber center. Drug penetration, we can talk later. Okay. Thank you. Good. Introduction class section. ఇది బాగానే అనట్లేదండి నెక్స్ట్
Good afternoon. Today's class is about Meniere's disease. So, definition: a disease of a membranous inner ear characterized by episodic vertigo, fluctuating hearing loss, tinnitus, and oral fullness, which has its pathological correlate as hydropic distension of endolymphatic system. It is also called as endolymphatic hydrops or auricular glaucoma. It has a triad of symptoms, mainly episodic vertigo, fluctuating sensorineural hearing loss, and tinnitus. Should remember it is a fluctuating hearing loss and it is not conductional, it is sensorineural, not a conductive hearing loss, and an episodic vertigo, not a continuous vertigo. These three are the triad of Meniere's disease. But oral fullness is an extra symptoms. If you are asked about the triad in your questions, you should mention these three, excluding the oral fullness. Oral fullness is an extra symptom. So before going into the pathophysiology of Meniere's disease, let's discuss a little about the anatomy of the inner ear. So this is the inner ear. As you know, inner ear or aortic labyrinth is divided into two parts, bony labyrinth and membranous labyrinth. So this part is bony labyrinth and this blue color structure is membranous labyrinth. So membranous labyrinth is present within the bony labyrinth. So here you can see two compartments, outer compartment and inner compartment. So outer compartment is filled with fluid called as perilymph, whereas inner compartment is filled with the fluid called as endolymph. Both are different in composition. If we compare both perilymph and endolymph, the perilymph has more amount of sodium, whereas endolymph has more amount of potassium. And there is a potential in endolymph, whereas there is no potential in the perilymph. Moreover, we can say that the perilymph is equivalent to extracellular fluid, whereas endolymph is equivalent to intracellular fluid. So that they should be separated to avoid electric potentials. So if we take a cross section of a part of cochlea, of a coil of cochlea here, I'll show you. So this is a cross section of a single coil of cochlea. Here we can see the blue color one is the perilymph, whereas orange one is endolymph. So they are separated by membranous labyrinth. So perilymph and endolymph are not in continuation, but on stimulation, auditory or by vestibular stimulation, a little amount of perilymph will enter into the endolymphatic cavity. This results in the electronic disturbances that results in stimulus or action potential, which is conducted along the cochlear nerve. So that is the way hearing is being produced. I mean, hearing is being conducted. So coming to the pathology of Meniere's disease, it is because of increased amount of endolymph. So this part of the cavity or this compartment is getting more amount of fluid, that is endolymph. So the membranous labyrinth bulges because of increased amount of endolymph. This results in oral fullness. The patient will be complaining of oral fullness. Oral fullness means blocking sensation in the ear, as if water has been blocked in your ear. That symptom is called as oral fullness. So patient will be complaining of oral fullness when there is high drops initially. If the pressure keeps on increasing, at one instant, at one point, the membrane ruptures here. Then suddenly the perilymph and endolymph get mixed and abnormal electrophysiology occurs, which results in abnormal stimulation of both as well as vestibular apparatus. This results in the episode of vertigo, tinnitus, and hearing loss. So the pathology includes either because of increased production of endolymph or because of decreased absorption of the endolymph. So production of endolymph occurs at stria vascularis. This part in the cochlea is called as stria vascularis. It is a vascular strip which secretes endolymph into the cavity, whereas it is excreted or removed by endolymphatic sac. This is the endolymphatic sac. So it is secreted in the cochlea by stria vascularis and it is excreted out through endolymphatic sac. So either because of increased production in the stria vascularis or because of decreased absorption or abnormality here, results in the increased amount of endolymph fluid. That results in endolymphatic hydrops. Causes include genetic, which includes 20%, mostly autosomal dominant, and anatomical defects of labyrinth, trauma, viral infections, allergy or autoimmune diseases, syphilis, chronic otitis media, or abnormal fluid balance. So pattern of attack, whenever the membrane gets ruptured, as I previously told you, when the membrane's labyrinth gets ruptured, first the patient will land up in vertigo. It's a severe vertigo which is followed by deafness. It is a sensorineural deafness, which is followed by again tinnitus. This is the pattern of attack in case of a Meniere's disease. The clinical features include episodic vertigo and sensorineural hearing loss, which is fluctuant and progressive, and especially low frequencies are involved, not the high frequency. That is the cardinal feature of Meniere's disease. Tinnitus and oral fullness. Another concept called as trio phenomenon. In this, whenever a patient is exposed to the loud sounds, the patient will be having syncope, vertigo. Investigations include pure tone audiometry. In pure tone audiometry, this is a pure tone audiometry. Sensorineural hearing loss is seen, which is mostly affecting the lower frequencies. These are the lower frequencies and these are the higher frequencies. So Meniere's disease is only affecting the lower frequencies. That results in the tip left side of the curve. In speech audiometry, speech discrimination scores false, and special tests include recruitment test is positive, soft treatment sensitivity index scores are more than 70%, tone decay is negative. Other investigations like electrocochleography, in which potential and maximum potential ratio is increased, resulting of potential ratio. In caloric canal perisis is observed, and glycerol test is positive. So these are some other variants of Meniere's disease. Lermion's syndrome. In this syndrome, first patient we have sudden sensorineural deafness, which is followed or immediately improved after the attack. In classical case of Meniere's disease, patient initially presents with vertigo, but in Lermion's disease, the patient presents with SN, sensorineural deafness, which is followed by vertigo. And these help to decrease the amount of endolymph being secreted into the endolymphatic sac, into the middle ear. So treatment proper includes, you have to differentiate whether it is an acute episode or a chronic prophylaxis. And it is again divided whether it is a medical treatment or surgical treatment. Surgical is again divided whether it is a destructive treatment or permanent one or a non-destructive one. So in case of an acute episode, as I told you, when a membrane ruptures, an acute episode of an Meniere's presents with vertigo, a severe vertigo. So we have to give vestibular sedatives, which will prevent the vertigo, like dimethylnitrate, promethazine, or chlorpropyrazine. This helps to alleviate the symptoms. And vasodilators help for drainage of the endolymph by decreasing the endolymphatic pressure and bed rest. In case of chronic phase or prophylaxis, vestibular sedatives and vasodilators can be used. The diuretics are best effective, but not in acute conditions. Diuretics help to decrease the amount of fluid in the endolymphatic sac. Not in acute conditions. They do not act in acute conditions. Vestibular sedatives act in the acute conditions. Coming to surgical treatment is reserved for cases in which the medical treatment fails. It is a controversial. So as I've told you, it is divided into two major classifications. It is a destructive procedure or a non-destructive procedure. There are four types of surgical treatments for Meniere's disease. First one is endolymphatic sac decompression. Next is vestibular neuronectomy. And intratympanic gentamicin injection. Fourth one is labyrinthectomy. Next one, endolymphatic sac decompression or shunting. As I have told you, endolymphatic sac, this is the endolymphatic sac and it is the excretory point of endolymph. So in this surgery, we'll drill the bone around the endolymphatic sac. We'll remove the bone around the endolymphatic sac so that the reservoir is increased. The endolymphatic sac can bulge more, resulting in increasing the reservoir content of the endolymphatic sac, thereby reducing the pressure in the endolymph. Or another thing is, this is the dura, this is the subarachnoid place. We can create an opening here and make a shunt into the subarachnoid place, thereby decreasing the pressure in the endolymphatic sac. This is a non-destructive surgery, and in this surgery, we are preserving all the inner ear, all the vestibular apparatus as well as cochlear apparatus, and minimal surgery. So the success rate about 50 to 60% for this. Coming to destructive surgeries, vestibular nerve section. This is reserved for the patients in which the hearing is good, the hearing of the affected ear is good, and we have to dissect the vestibular nerve. As you know, vestibular nerve is a part of eighth nerve, cochlear. So this is the vestibular cochlear nerve. So it has two parts in that, vestibular part and cochlear part. Cochlear part is for hearing. So we have to conserve that cochlear part because hearing is good in this particular patient. So this is the internal auditory meatus. In the medial side of internal auditory meatus, the nerve centers as a single nerve, and later, if it while it goes laterally, it divides into, this is a cochlear nerve, and this is the vestibular nerve, which further divides into superior and inferior vestibular nerves. So we have to dissect the vestibular nerve at this point to avoid damage to the cochlear nerve. We are preserving the cochlear nerve here. For this, we have to reach the internal auditory meatus without damaging this in labyrinth and dissect this vestibular nerve. Next procedure is labyrinthectomy. This is a management option in which both the hearing as well as the vestibular apparatus are destroyed. It has a highest cure rate, about 95%, but it's a destructive surgery and it's a permanent destruction. Okay, so this labyrinthectomy involves ablation of the inner ear. It destroys the inner ear. This procedure is less complex compared to the vestibular nerve section. Because see, this is the anatomy of inner ear. This is the external auditory canal, and this is the internal auditory canal. This is inner ear. This is middle ear. So, in case of vestibular neurectomy, as I have told you previously, this is the internal auditory canal, and this is the eighth nerve, vestibular cochlear nerve. To reach the vestibular cochlear nerve without damaging this all inner ear and the middle ear, we have to go via the cranial cavity. So, this is the middle cranial fossa. By entering into the cranial cavity, craniotomy is done and brain is retracted, and then near the brainstem, we'll identify the nerve, and then we'll go into the separation and we'll separate. In this way, we are preserving the inner ear. We are not damaging the inner ear. It's a bit difficult procedure because we are opening the cranial cavity. It may result in CSF leakage and other complications. Whereas in labyrinthectomy, now labyrinth is being destroyed. We need not go all the way into the brain, into the internal auditory meatus. We can go directly into the labyrinth along the ear cavity, and we can destroy this cavity. So by ablation of the inner ear, we can prevent the damage to all the tissues. But it's a destructive surgery. We are destroying as well as the hearing as well as the vestibular apparatus. So this procedure carries less danger of CSF leak and meningitis since craniotomy is not required. Like those who undergo vestibular nerve section, the patient requires few days of inpatient care, and accommodation to surgical loss of one vestibular apparatus usually takes weeks or months. So vestibular rehabilitation during this period is also helpful. Another procedure is transtympanic perfusion of medication or transtympanic injection of medication. We usually use gentamicin for that. The medication for meningitis is applied to the laryngotomy with the middle ear. By using a needle, we'll insert into the tympanic membrane. We'll make an opening in the tympanic membrane and we'll insert into the tympanic membrane. And the gentamicin injection is given into the middle ear, not into the inner ear. So that this gentamicin is absorbed through the round window into the cochlea and the vestibular apparatus. It has a destructive property of sensory epithelium of both cochlea as well as labyrinth. It is a minimal invasive surgery, but it's a destructive one because it destroys all the sensory epithelium of cochlea and vestibular apparatus. So it is equal to a labyrinthectomy, but with minimal invasion. Thank you.